Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
You make the incision, the pus drains, the patient gets instant relief. I mean, it is the classic surgical win, right?
Oh, absolutely. It's incredibly satisfying in the moment.
Right. But then say 3 months later, you're sitting in your clinic and that exact same patient is back. They're guarding, they're miserable, the pain has returned.
Yeah, the nightmare scenario.
Exactly. What seemed like a, routine, straightforward procedure has just turned into this recurring nightmare for the patient and, frankly, a massive clinical frustration for you as the operating surgeon.
It really is. It's one of the most frustrating things we deal with.
So if you're tuning in today, you are likely a surgeon, an ER physician, or some other medical professional navigating this very real high-stakes world of acute care in the operating room.
Yep, the people on the front lines.
Right. And today, our mission for this deep dive is unpacking the MRI roadmap for complex perianal abscess management. We're pulling from recent radiological guidelines, surgical retrospective series, and pelvic imaging consensus papers to figure out how we actually break this cycle of recurrence.
It's so needed, too, because the old paradigms just aren't holding up.
They really aren't. But before we get into the anatomical weeds, I need to state our mandatory clinical disclaimer. This content is for reference purposes only. Always follow local guidelines in your own clinical practice.
Right. Your own intraoperative judgment and local clinical guidelines always dictate your final approach. We are just here to synthesize the data on how advanced imaging is, shifting that decision-making process.
Exactly.
Because that standard paradigm of, see an abscess, drain an abscess, it's completely falling apart when we look at the long-term recurrence data for complex perianal sepsis.
So what does this all mean? Where do we even start to fix this?
Well, we have to start by looking at the physical exam, which is the traditional cornerstone of this whole process.
Okay, so picture it.
Yeah.
You have a patient in the ER, severe perianal pain.
Right. And visual inspection might show some asymmetry, maybe some overlying skin changes. You try a digital rectal exam. But the clinical reality is that the physical exam is essentially leaving you blind in these complex cases.
Because we're dealing with an anatomical zone where the actual source of the infection is completely hidden from view.
Exactly. You are looking at the downstream effect, not the actual source. I mean, the pathogenesis of most perianal abscesses originates at the dentate line.
Right, deep inside.
Yeah. The anal glands penetrate the internal sphincter, they become obstructed, and the infection begins in that inner sphincteric plane. From there, it just follows the path of least resistance along the fascial planes.
So that swelling you see on the perianal skin, that's just the terminal end of the process.
Exactly. By relying solely on visual inspection, we completely ignore the entire upstream network. We ignore, deep space disease extending into the ischial fossa or tracking upward into the supralevator compartments.
It makes me think of an analogy. It's like a persistent garden weed.
Oh, that's a good one.
Right, because if you just clip the visible top of the weed, which is the equivalent of a superficial incision and drainage, without actually seeing the deep root system, the hidden cryptoglandular extensions, it is absolutely guaranteed to grow back.
That is exactly what happens. It's a perfect analogy. And the mechanics of it, it's like a high-pressure water leak behind the drywall of a house.
Oh, yeah, because if you just patch the wet spot on the paint, you haven't fixed the burst pipe deep in the wall. The structure's just going to keep rotting.
Exactly. The water, or the sepsis in this case, finds new path along the studs and joists. When that intersphincteric gland ruptures, that purulent fluid is under immense pressure.
So it's forced outwards.
Yes.
Yeah.
It tracks laterally through the external sphincter into the ischioanal space, or it goes vertically. And the reason the digital rectal exam fails to map this out isn't just because the anatomy is complex.
It's the patient's reaction.
Right. It fails because of the physiologic response.
Yeah.
An awake patient with acute, deep pelvic sepsis is in agonizing pain.
I mean, you literally can't touch them.
Exactly. Their pelvic floor muscles, the levator ani, the external sphincter, they are in severe spasm. You cannot accurately palpate a supralevator extension or a complex horseshoe tract when the patient is just rigidly guarding.
You're fighting their own protective reflexes, which means if you take that patient to the OR based solely on that limited physical exam, your surgical plan is fundamentally flawed from the very moment you pick up the scalpel.
You're flying blind. You might drain the obvious ischioanal collection, but you leave the hidden supralevator extension completely untouched.
You leave the burst pipe leaking.
Yep. And that failure to achieve complete source control, that is the primary driver of recurrence. The residual infection smolders, the tract epithelializes, and the patient just returns a few months later with a persistent fistula or another acute abscess.
So to break this cycle, we have to look past the superficial tissue. We need a modality that bypasses the patient's guarding and actually maps out that entire fascial network.
We need the MRI.
Right. Our sources for this deep dive are incredibly clear that pelvic MRI has become the gold standard for mapping this exact anatomical dark zone.
It's a game changer.
But, okay, let's unpack this for a second. Let me play devil's advocate.
Sure.
If a patient comes back into the clinic with recurring pain after a previous drainage, isn't it obviously just the same infection flaring up? We already know they hurt. We know they're swelling. Why put them through a lengthy, expensive scan just to confirm what our clinical intuition is already telling us that they need to be drained again?
Okay, what's fascinating here is that your clinical intuition actually cannot differentiate between an active pocket of sepsis and chronic fibrotic change.
Wait, really? The exam can't tell the difference?
No, because when a patient presents with recurrent symptoms after a prior surgery, the anatomy is already severely distorted, the tissue is indurated, you palpate a firm mass, right?
Right.
But is that a new undrained abscess cavity, or is that just dense scar tissue from the previous incision?
Oh, wow. I see the problem.
If you go in blindly to drain what you think is an abscess, but it's actually scar tissue, you are causing unnecessary iatrogenic trauma to the sphincter complex.
Yeah.
And you're providing zero clinical benefit.
Ouch. Yeah, that's not good. So this is where the specific MRI sequences become the ultimate tool, because we're not just looking at a static anatomical picture, right? The sources emphasize two specific techniques: contrast-enhanced MRI and diffusion-weighted imaging, or DWI.
Right. The DWI is crucial.
If you're standing over the patient with a scalpel, the DWI sequence is essentially giving you X-ray vision into the cellular density of that tissue. How does the physics of that actually translate to the surgical map?
Well, it comes down to fluid dynamics at a microscopic level.
Yeah.
So diffusion-weighted imaging measures the random movement of water molecules in the tissue.
Okay.
In healthy tissue, or say a simple post-surgical seroma, water molecules move relatively freely. But an active abscess is filled with pus. And pus is highly cellular, highly proteinaceous, and incredibly viscous. It's packed with inflammatory cells and debris.
So the water molecules are literally trapped. They can't move freely through that dense, viscous fluid.
Exactly the mechanism. That restricted diffusion makes the active abscess light up brightly on the DWI sequence. It appears as a hyperintense signal, while the surrounding edema, or simple fluid, just drops out and looks dark.
That is amazing. You get a stark, high-contrast map of the exact location of the viscous, infected fluid.
Yeah, and the data shows that in complicated fistula cases, this DWI sequence performs very similarly to contrast-enhanced MRI for defining the extent of the abscess, which is huge for patients who might have contraindications to intravenous contrast.
Right. If they can't handle the contrast, you still have a great map. But when you can use contrast, the gadolinium enhancement just adds a whole other layer to that map, right?
Absolutely. Gadolinium leaks out of the highly permeable capillaries in actively inflamed granulation tissue.
So the active stuff lights up.
Exactly. The walls of the active fistula tract or the abscess cavity will brilliantly enhance, but the mature, dense, non-vascular scar tissue from their previous surgeries that won't enhance at all.
So you're literally combining these layers. The T2 weighted sequence gives you the high-resolution anatomical baseline. It shows you the sphincter muscles, the levator plate, the fascial boundaries.
Yep, the physical landscape.
And then you overlay the DWI and the contrast sequences to pinpoint the exact physiological activity within that landscape. You locate the primary cavity, trace the secondary branching tracts, and pinpoint the internal opening at the dentate line.
And crucially, you map the relationship of all that active infection to the sphincter complex. You cannot protect the continence mechanism if you don't know exactly where the infection sits in relation to the internal and external sphincter muscles.
That makes total sense. But let's bring this back to the reality of a busy hospital. Say it's 2 a.m. You have a patient in the ED in severe pain.
The classic scenario.
Right. And CT scanners are right down the hall in the emergency department. An MRI requires scheduling, pre-authorization, maybe waiting until the next day. A CT scan takes 5 minutes. Why shouldn't a surgeon just get a quick CT to check for a collection and head to the OR?
Well, a CT scan will certainly confirm the presence of a large fluid collection. It relies on tissue density, measured in Hounsfield units. But the clinical question in these complex recurrent cases is no longer simply, is there an abscess?
Because we already know there's an issue.
Right. The question has evolved. You need to know how far it extends, where the internal opening is, and whether there is an associated complex fistula network.
And a CT scan just lacks the soft tissue contrast to give you that answer.
Precisely. You might see the large fluid pocket in the ischianal space on a CT, but you are not going to see the 2-millimeter fistulous tract threading its way through the fibers of the external sphincter.
The resolution for that specific soft tissue differentiation just isn't there on a CT.
It's really not. And without seeing that tract, your surgical intervention will be incomplete. You will drain the obvious cavity and entirely miss the underlying cryptoglandular source.
Okay, what about endoanal ultrasound? Because a lot of practices have ultrasound probes readily available, and they offer excellent visualization of the sphincter complex, right?
They do, but there are two severe limitations with endoanal ultrasound in the acute setting. First, it requires inserting a rigid probe into the anal canal of a patient who is already experiencing excruciating pain.
Oh, right. We're back to the same limitation as the digital rectal exam.
Exactly. The patient just cannot tolerate it.
Hmm?
And second, the depth of penetration with ultrasound is limited. It really struggles to accurately visualize complex disease extension high up into the supralater spaces or deep into the ischianal fossa.
So the sound waves just can't penetrate deeply enough with enough resolution to map those distant tracts.
Right, which leaves MRI standing alone as the definitive modality for providing a comprehensive three-dimensional surgical roadmap.
But, I mean, this requires strict triage. We can't just bottleneck the radiology department by ordering an MRI for every single patient with perianal discomfort.
Oh, definitely not. The guidelines establish very specific indications to ensure we are scanning the patients whose management will actually change based on the imaging.
So the decision tree is highly specific. And looking at the sources, the most absolute indication is recurrent perianal abscesses.
Yes, that's number one.
If the patient has had a prior incision and drainage and the sepsis has returned, they need the scan. The first surgery failed for a reason, and you need to see the hidden anatomy before you attempt a second blind procedure.
Exactly. Another primary indication is suspected deep space disease. This is your classic iceberg scenario. The patient presents with severe, deep-seated pelvic pain, maybe systemic signs of infection, but your external visual findings are minimal.
So they hurt really bad, but you don't see much on the skin.
Right. That lack of superficial fluctuance in the presence of severe pain is a massive red flag. It means the infection is tracking superiorly into the supralevator space rather than superficially.
You also have to consider the patient's underlying pathology, right? The guidelines strongly recommend MRI for any patient with Crohn's disease or other inflammatory bowel diseases presenting with perianal sepsis.
Oh, absolutely. Fistulizing disease is incredibly common, highly complex, and notoriously difficult to manage in that population. You never want to operate blindly in a Crohn's patient.
Yeah, that sounds like a recipe for disaster. And you also need an MRI anytime you suspect a fistula in ano, especially if sphincter-sparing surgery is being considered.
Right. If you're planning a lift procedure or an advancement flap, you need a millimeter-perfect anatomical mapping of that tract.
But conversely, for a straightforward superficial perianal abscess that is obviously fluctuant on the skin margin with no history of recurrence, an MRI is just a waste of resources.
Completely. It will not change your management. You just numb the superficial area, incise, and drain.
Okay, so let's transition from the radiology suite back to the operating room. We've established the theory, we understand the physics of the scan, and we have the triage tree. But how does this map actually transform the physical strategy when you are standing over the patient?
Let's walk through a clinical scenario to see this in practice.
Okay, let's do it. Say you have a 45-year-old male presenting with his second recurrence. The clinical exam shows severe induration on the right perianal side.
All right, so if you proceed without advanced imaging, based solely on that right-sided induration, your plan is a standard right-sided incision and drainage. You open the ischianal space, you find pus, you place a drain, and you consider the case closed.
Right. You feel like you've achieved source control. You did your job.
But let's say we followed the guidelines and obtained the preoperative MRI because of his recurrent history.
Okay. Here's where it gets really interesting.
Exactly. The T2 and DWI sequences reveal the large right-sided collection. However, they also reveal a deep horseshoe extension communicating via the deep postinal space all the way over to the left ischianal fossa.
Wait, so there is an entire secondary network of sepsis on the contralateral side that had absolutely no visible external signs?
None at all. And this fundamentally alters your surgical approach. If you had performed the blind drainage, you would have completely missed the deep postanal communication and the left-sided extension.
So the left side would remain undrained, the patient remains septic, and the recurrence is 100% guaranteed.
Yep. But with the MRI roadmap, your procedure changes entirely. You don't just do a simple right-sided incision. You are now planning for a complex, staged management approach.
So you might place a draining seton through the main tract to allow the deep postinal space to drain properly without cutting the sphincter.
Exactly. You convert a presumed simple 15-minute procedure into a highly calculated sphincter-preserving operation. You might even realize during the preoperative planning that the complexity of the horseshoe tract requires an urgent referral to a dedicated colorectal specialist.
And this brings us to the paramount concern in all perianal surgery protecting the sphincter complex. Every time a patient is subjected to a repeated blind operation, the risk of iatrogenic injury to the internal and external sphincter muscles increases exponentially.
You are just cutting through inflamed, distorted tissue without a clear guide. It's so risky.
And the retrospective surgical series cited in our sources provides hard data on this. They demonstrated that utilizing a preoperative MRI is associated with significantly lower recurrence rates.
And even more importantly, it results in a drastically higher detection rate of the underlying primary fistula tract compared to surgery performed solely on clinical intuition.
So the map definitively works. It guides the scalpel away from the muscle fibers and directly toward the source of the sepsis.
The whole clinical paradigm shifts entirely. We move from reactive management, chasing the pus wherever it happens, to point on the skin, to proactive anatomical management.
Right. So the clinical exam identifies the problem. The MRI defines the anatomy. And surgery provides the source control perfectly guided by that defined anatomy.
You systematically dismantle the cryptoglandular network rather than just patching the leak.
It's brilliant. But we do have to address the absolute golden rule of sepsis management. The one major limitation to everything we have just discussed regarding advanced imaging.
Yes. The limitation is patient stability. An MRI, or any imaging modality for that matter, should never, ever delay urgent surgical drainage if a patient is, frankly, septic, hemodynamically unstable, or presenting with a rapidly progressing necrotizing infection.
Source control comes first. You do not leave a toxic hypotensive patient waiting in the radiology hallway for an MRI slot to open up.
Never. The MRI is a powerful adjunct for complex disease. It's a planning tool to prevent long-term recurrence and protect continence. It is absolutely not a replacement for prompt, life-saving surgical treatment when the patient's systemic condition demands immediate intervention.
Right. If they're crashing, you act.
Exactly. If they're unstable, you take them to the OR, achieve whatever source control you safely can, and perhaps utilize the MRI in the postoperative phase to map any residual disease once they're actually stabilized.
That distinction is so critical. So as we wrap up this deep dive into the imaging and management of complex perianal sepsis, we really need to reframe how we view the utility of these scans, because we frequently hear debates about the financial cost or the logistical time delay of ordering a pelvic MRI in a busy hospital system.
We hear it all the time. But we need to weigh those upfront logistical costs against the long-term physiological costs to the patient. Repeated blind operations drastically increase the risk of irreversible sphincter damage.
Which is devastating.
It is. The true cost of skipping a preoperative MRI at a complex recurrent case isn't just a missed fistula tract or a temporary return of pain. The real cost is potentially the irreversible toll on that patient's lifelong continence and their overall quality of life. The scan protects the patient's future just as much as it guides your scalpel today.
The scan protects the future. I love that. It provides the X-ray vision required to actually find the burst pipe in the wall, ensuring you aren't just patching the paint while the structure rots. Well, if you found this clinical deep dive valuable, please do not forget to share it with at least one of your colleagues or friends to help spread the word. We really rely on you to get this information to the medical professionals who are actively navigating these difficult clinical scenarios. Also, make sure to check out our YouTube channel and our other social media pages for more detailed clinical breakdowns and imaging reviews.
Our goal is to consistently bridge the gap between the evolving radiological evidence and the practical realities of the operating room.
And to that end, do check out our previous season and episodes. They are packed with some very relevant topics, deep dives into acute care surgery, complex imaging guidelines, and clinical decision-making designed specifically for medical professionals. Thank you so much for joining us, and we will see you on the next Deep Dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe.
Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.